I'd also like to acknowledge the presence of our partners from the States. Um, Malam Abubakar Hassan, the Director General of the Kaduna State Contribution Health Management Authority. I'd also like to acknowledge Dr. Dutse Musa, the Director of the Health Planning, Research and Statistics at the Kaduna State Primary Health Care Development Board. Also, Bashir Mohammed MNI, the Permanent Secretary from the Ministry of Budget and Planning. We also have our distinguished development partners present. Temi Dayo Akinola from Chai. We have Dr. Abdul Rashid Bello Alia from WHO. We have Dr. Salisu Agungu from Pathfinder. We have Dr. Anthony Shaman from McKinsey Consulting. We also have Dr. Kabiru Atta from Engender Health, and we have Fun Shole from Chai. You are most welcome. Thank you for honoring our invitation to join us on this very important event. At this point in time, I'd like to call on our director of program, Dr. Kemisola Baoye, for the welcome remark. Round of applause for her, please, as she takes the stage. Thank you.
Good morning, everyone. I would please permit me to stand on the existing protocols and also give a very special welcome to all of our distinguished guests and partners. Thank you so much for being here. We all know that primary health care is the bedrock of any healthcare system and is vital, critical to the achievement of universal health coverage, which is particularly pertinent as we inch closer to 2030, which is the timeline for the Sustainable Development Goals. Now, in Nigeria, we have over 30,000 primary health care centers, only 20 of which are functional. And we know that there have been a number of investments recently to try to fix this. For example, the Basic Healthcare Provision Funds, the KPC under One Roof Initiative, but the challenges persist. So we know that there are challenges around 15, it's still over 500. But if we look at more recent data, because we're still waiting for the validation of NDHS, of the last NDHS that was conducted, WHO quotes figures above 8,000. In Kaduna, there are figures that are above 400, some say over 800. Child health under 5 mortality is still over 150 per 1,000. This is way above what the averages are and what the Sustainable Development Goals targets are. But Kaduna was one of only 5 states in 2024 that achieved a 15% budget allocation to health, along with Bauchi, Abia, Yobe, and Kano. So we're saying that Kaduna is setting the pace, is an example in terms of budget allocations, but then just as we're seeing across the country, the translation of those allocations to releases and improved service delivery at primary healthcare centers remains a challenge. Kaduna has also done some things around improving accountability. So you have the Kadma mechanism, the Kaduna state-led accountability mechanism that the state currently frontlines and pushes using evidence-based advocacy to advocate for improved allocations to the health sector. There's also the community maternal perinatal death surveillance review, surveillance response, MPDSR, that Kaduna has been implementing. So there's a lot to learn from Kaduna, but there are challenges that Kaduna does need to address, such as issues with cash backing, the timely release of funds, and utilization of those funds for improved service delivery. There's also, of course, workforce shortages, which cuts across everywhere, not just Nigeria, across the world as well. So that's why we thought to host this policy dialogue in partnership with key partners in the room already acknowledged, and Gender Health, with the McCain consultants here, and all of the other Gates Foundation partners. We also have partners in the room from WHO, from CHAI, and other organizations. And the objectives are simple. How can we address budget allocation and fund disbursement challenges in Kaduna State so that the monies that are being allocated to the health sector get to the primary healthcare centers and translate to improved service delivery? How can we advocate for transparent financial tracking mechanisms? How can we make sure that budget performance is optimized, is documented, and reported in a way that is transparent, and the citizens themselves are involved in tracking all of this? We have partners that are already doing that, like budget. How can we explore approaches to strengthen the PHC workforce capacity in the states? How is Kaduna State implementing the tax shifting, tax sharing policy, for example? And what can other states learn from that? How can we make sure that funds are released in a timely way to the Primary Healthcare Board and the Kaduna State Contributory Health Management Agency as well? These are the things that have brought us together as an ecosystem, stakeholders in the Nigerian healthcare sector. So on behalf of Nigeria Health Watch, Gender Health, and all of the other partners who came together to put this policy dialogue together, I'd like to say a big welcome. Thank you for making the time to be here. We're very aware of all of the competing priorities that you had to battle to be here. So thank you very much. We do not take that for granted, and we look forward to fruitful deliberations and to what comes out of this dialogue. Thank you.
Please, a round of applause again. I think a round of applause for Kaduna State. Just as Dr. Kemisola had mentioned, Kaduna has been the trailblazer in terms of setting the standard for other states to follow in terms of the healthcare budget allocation over 15%, and also the accountability mechanism to ensure that service delivery remains optimal. So a round of applause again for Kaduna State. Thank you. At this point, I'd like to introduce Safia Issa, who is our Deputy Director for Partnerships and Advocacy in Nigeria Health Watch. A round of applause for her as she takes the stage, please.
Thank you, Chris. Good morning, distinguished guests. Thank you so much for making out time. When I arrived on Tuesday and saw the lineup of activities at Hotel 17 and how you, the Honorable Commissioner for Health, the Director General Contributory Healthcare Scheme, and the ES, and all the directors were shot between meeting rooms. I said, yes, Kaduna is highly favored. You have a lot of partners ready to support, and we have come to join that lineup. So I was born and raised in Kaduna, and just as I was being announced, my mom just came in. I'd like to just mommy, please say hello. Just recognize and give her that honor. So primary health care is something that is personal. She accesses the PHC services in Warini. That's where I was born. And she goes there. All my siblings that are still here in Kaduna with her, they all access PHC services. So for me, it's supporting this is a lived experience. It's a personal story, and I'm totally committed. So as Kemi has beautifully laid the foundation, I would like to tell you about our community engagement project and a little about Nigeria Health Watch as well. So if you can just bring up the slides so that our guests can follow as I So we're a health communications and advocacy organization. Our founders started in 2007, and they started as a blog, just generally raising awareness and raising questions as to why policies are not translating into implementation. And they were passionate about also equipping the populace about details of how they can take care of their health and well-being. And fast forward from 2007 till date, we're a fully fledged not-for-profit organization supporting maternal health, nutrition programs, routine immunization, strengthening achievement of universal healthcare coverage, of which primary healthcare is pertinent and key to that. So this is our community engagement project, and it is part of our global policy and advocacy project. We have a project that is very dear to us called the Community Health Watch, and it is community focused, community centered, where we take the perspective of community members accessing services, being able to also communicate these experiences to our policymakers who are here in the room so that they're informed about what the specific need is to meet at every specific PAC in a ward or in a local government or in a community. And as Kemi also mentioned, we piloted in Kano and Niger, and we're ready to come to Kaduna. But with this policy dialogue, we're very specific about the funding situation and the health workforce capacity in our state. So I have said a little bit about who we are, our focus areas, and I'd like to speak a little about the background of the Global Policy and Advocacy Project. And it is that Nigeria faces high maternal and child mortality rates, weak health accountability systems, which limits progress towards achieving our SDG goals. And I learned that we've moved up to the top of that list, not a very good list to be on top, being the highest contributor to maternal mortality deaths globally. So we're really, focused on strengthening primary healthcare through this community engagement project at the subnational level. We want to amplify citizens' voices and see the transformation of service delivery. Our project is 5-year funded by the Gates Foundation, and we started last year, so we're in the 2nd year of implementation. These are our objectives: increase knowledge and awareness of focus areas at the national and subnational levels in Nigeria, select African countries, to increase learning and sharing of innovative, effective healthcare policies, and to improve engagement with decision makers such as yourselves in the room. Apart from our community engagement strategy, we also do misinformation management. This is where we deploy our community listening to understand what the rumors and the myths and the misconceptions in the communities are that we need to address. We're also partnering with Kenya, Uganda, and Ghana to have a cross-learning and experience sharing, especially working with other civil society organizations and health and advocacy organizations like ourselves. We're neck deep in communications, partnerships, advocacy, and policy. I've mentioned our focus areas, but MNCH, routine immunization, primary healthcare, universal health coverage, SR, HR, and nutrition. Project strategies. So we always conduct a landscape analysis from which we now deploy our community health watch reporters who tell localized context-specific stories. We also do radio programs. Yesterday, I was at Freedom Radio to talk about.
Permanent secretary here present, heads of agents, representatives of other MDAs, developmental partners, traditional and religious leaders, representatives of civil society, the media, distinguished ladies and gentlemen, morning. Our state, Kaduna, contains a teeming population of over 10.6 million, with a larger proportion of females and a greater number of youths than any other age. The state faces recurrent healthcare burdens and service delivery challenges, which are related to this peculiar demographic distribution. In addition to this, we are currently recording a multidimensional poverty index of 88%, with a higher value of 89% for females. It's therefore essential that universal healthcare delivery is achieved for all and access to care is equally available to all subsets of the population. We, seated here as key stakeholders, must recognize that equity in healthcare delivery is crucial and commences with intentional investments at the primary health. Over the past few years, the state has taken important steps in managing the Basic Healthcare Provision Fund to channel resources directly to primary healthcare facilities. However, we also understand that sustainability is not guaranteed by funding alone. It requires transparent disbursement and tracking mechanisms, community participation in budget planning and monitoring, and a commitment to result-oriented spending. To ensure this, we are exploring models such as state-level health trust funds, performance-based financial pilots, and the integration of community-based health insurance schemes to improve equity and reduce out-of-pocket expenditure, particularly for the poor and vulnerable in our population. As the cost of healthcare has become prohibitive and unattainable by most of our populace due to the high cost of basic living requirements such as feeding and accommodation. Distinguished ladies and gentlemen, we have arrived at a critical moment in our collective push for an efficient, equitable, and quality health system, especially at the primary healthcare level, which is one of the strategic visions of the Federal Ministry of Health and Social Welfare. Despite the drive to improve healthcare financing, it's imperative we pair this quest with a commitment to sustaining quality. Any system can only work if the components needed to run it are in place and well-maintained or sustained. We as a nation are currently facing a human resource for health due to the loss of staff from attrition, the notorious JAPA syndrome, and in Kaduna State, a specific peculiarity, internal shifts from public facilities to private and tertiary healthcare facilities proximal to those belonging to the government. Kaduna State has had to confront the twin challenges of health workforce shortages in addition to rural-urban distribution. Fellow stakeholders, we must acknowledge that no PHC system can be equitable if healthcare workers are unavailable, overburdened, or unsupported. Kaduna State, therefore, to handle this, in partnership with non-governmental organizations, developed a human resource for health quality, which has been approved and passed into law. And we have also generated a costed implementation plan that has obtained executive approval to commence recruitment processes. This will enable us to implement effective measures, such as recruitment of midwives and CHIPs for underserved wards. It will enable us to reposition the Primary Healthcare Development Agency to improve training, supervision, and workforce planning. It will also enhance collaboration with partners to develop continuous professional development, particularly in the areas of maternal, newborn, and child health services that can be achieved within a clearly laid out framework. The human resource for health policy of the state will also explore incentives, including rural hardship allowances and career progression schemes, so we can finally retain talent where it is needed in order to mitigate the state's brain drain challenge. Distinguished guests, in today's program, our panel discussions will focus on advancing sustainable financing for equitable healthcare delivery and also address workforce challenges in the primary healthcare centers. Both are thematic areas that speak direct to our current realities in Kaduna State and indeed challenges encountered across the nation. I urge you, as we listen to the panel today, to remember that policy shifts happen when stakeholders commit beyond discussions, technical sessions to act. The spirit we embrace in Kaduna is one of shared accountability and inclusive decision making. Let us bring it here today. I wish to reaffirm our acceptance as a state and as a people of ideas, innovations, and positive feedback that will definitely emerge here today, and also restate our readiness as a people and a ministry to act on evidence, amplify community voices, and build lasting partnerships. Permit me to express our profound gratitude to Nigeria Health Watch for sustaining the platform and spotlighting the people's needs at the heart of our healthcare system. I believe together we can build a PHC system that is financed with foresight, staffed with compassion, and governed with accountability. Thank you for your attention. I do hope you enjoy the rest of the sessions today.
Please, another round of applause. I think as we have rightly heard, the conversations today will be surrounding advancing sustainable financing for equitable healthcare delivery, and also exploring strategies for addressing workforce challenges in Kaduna State. These are all pertinent discussions in the goal or objective to improve health outcomes for the state. And so at this point in time, I would like to call on, would like to be introducing our first panel discussion, which will be focusing on advancing sustainable financing for equitable healthcare delivery in Kaduna. I'll be introducing Dr. Kemisola Agbaoye, who is the moderator for this panel discussion. So please, a round of applause for her as she comes to the stage. Round of applause, please. Thank you.
Good morning again. How's everyone doing? I'm tempted to say, hey, can we all just say hi? But there's been a lot of discussions already, so we'll just get right to it. Very mindful of. Okay, hi. Okay, so this panel discussion focuses on advancing sustainable financing for equitable healthcare delivery. And I have distinguished speakers, which I'll be introducing shortly. But we've already heard so much from the Permanent Secretary of the State Ministry of Health. And I'd like to quote one thing she said. She said, policy shifts happen when stakeholders commit to action. Beyond the discourse, beyond all of the talk that we're going to be talking here this morning, we really look forward to what then happens when those recommendations are implemented. And she also said she looks forward to a healthcare sector in Kaduna State that is financed with foresight. So to take us along in these discussions, please allow me to welcome the Honorable Commissioner for Planning and Budget in Kaduna State, ably represented by the Permanent Secretary, Mr. Bashir Muhammad MNI to the stage as he takes his seat. And secondly, please do put your hands together as I welcome the Honorable Commissioner for Finance, Honorable Ibrahim Tanko Mohammed, ably represented by Habib Lawal, the Permanent Secretary of the Ministry of Finance. To the stage. I'm sorry, I feel like the person is not quite here yet. Yeah, okay, apologies. And then Prof. Bello Jamor, the Executive Secretary of the Kaduna State Primary Healthcare Board. Please put your hands together for him as he comes up. Apologies. Ably represented by the Director of DPRS. I'm so sorry. Please welcome the Director of the Department of Planning, Research and Statistics. And finally, Malam Abubakar Hassan, the Director General of the Kaduna State Contributory Healthcare Management Authority. Oh. The Permanent Secretary of, please put your hands together for the Permanent Secretary of Finance as he comes in and takes his seat here. Thank you so much. And we also wanted to welcome the chairman of the House Committee on Planning and Budget of Kaduna State, who came in after the protocols were read out. You're welcome, sir. Very glad to have you. Okay, all right. So we know how much of a challenge financing can be. And I think to frame these discussions, I'd like to start with asking for some of the panelists to adequately frame what the issues with sustainable financing for primary healthcare actually are. And to get us started on that, I'd like to ask you, Malam Abubakar Hassan, Director General of Kachma. So what exactly are the challenges with financing? We've heard so much about how this poses a significant challenge for service delivery, and you actively engage with the primary healthcare facilities across the country, and you have this pooled amounts of funding from the formal sector for health insurance. What exactly are the issues with financing in ensuring that the financing gets right down to the grassroots, to the primary healthcare centers, and it translates to improved service delivery?
Thank you for the opportunity to really participate in this session this morning. In terms of issues around financing, I think what is critical to really look at the different levels of how financing really comes, different layers, starting from agency, for example, down to the primary healthcare level. Different actors involved along this value chain, from the government side to the partners who contribute to making sure that these things happen, facilities where services are delivered to the last mile, to the people. From the government side, I will tell you it is about a matter of understanding what our different responsibilities are with respect to ensuring that financing really happens. Number one is when we begin to look at finance as finance, we need to begin to look at how realistic our plans are. And our plans are a function of what we understand as our core priority of ensuring that we know that this is to translate into the level of service that come at the level of the facility. So realistic planning is a major constraint sometimes because when you plan outside of context, you are planning also to meet certain other state contending priorities. And so when your plans are not realistic, they will be meeting those other state contending priorities, and they may face challenge of getting to be approved in a good time. So it means in order for you to be able to lay a credible foundation for financing to happen, you must have a realistic plan. Realistic plan with a realistic budget that would meet other contending plans within the state. That is a major challenge. And in that respect, we also recognize the importance of partners' contribution to really aligning with this so that the technical expertise expected around what needs to be done at the level of what government functions, government departments, to be able to meet up with challenge is being supported at the level of the partners. So we need institutions of government to understand what planning is all about, to understand what budgeting is all about, and present it in the right format so that it can meet the approval of government. Beyond that, assuming that all of these are also right. At the level of service delivery, we're also looking at issues around understanding how these budgets are being spent and for what purpose. From the health finance, health insurance point of view, we're talking about strategic purchasing. To what extent do we get services at the level where medicines are going to be available at the level of facilities and other related associated issues, for example, human resources at the minimum base that we can afford at the level where someone can come into the facility to get the necessary service. So there is issue of capacity at that other level. The issue also in terms of understanding how to ensure that whatever that's been put out there in terms of financing is spent the right way and for the right purpose. But beyond all of this also is the issue of what capacity do we have to be able to report these finances that have been put out there at the end of the day. Your ability to report in a good time, your ability to be able to put these in the right format also allows you to be able to get appraised in a good time and also get the necessary financing that needs to happen. So understanding the different roles that we play as actors within the value chain around financing from policy to implementation becomes an impediment to financing around this entire system. We should be able to understand what our responsibilities are. We should be able also to be accountable to these finances that at the end of the day come out and get to these facilities so that the person we intend for this service to get to at the end of the day surely will get there. Thank you.
Thank you so much. So you've touched on a number of things. One is realistic planning, the capacities of the budget and planning officers themselves to understand how to plan for the health sector and how to allocate resources. But before we move on, because I feel like there are a number of people on this panel that can answer some of the questions you've posed, I wanted Dr. Duse Musa, Director of Health Planning, Research and Statistics at the Kaduna State Primary Healthcare Board, to also try to frame this problem. So what exactly are the challenges that are currently being faced in terms of delayed release of funds? What are the bottlenecks that you're encountering in making sure that funding gets to primary healthcare centers and it translates to improved service delivery?
Okay, like the PG Kachuma said, basically the process of assessing funds are basically layered, and issues around assessing funds are actually multifactorial. I will put some perspective into what he just said because they are the same issues really. Basically, it starts with the point of the officer that's responsible for the activity actually applying for that fund. Sometimes there's a disconnect. You find out the officer probably does not apply, maybe write a memo and all that. And then, like I said, the process are layered because you write, it goes through a process within your agency before it goes to planning and budget commission, then goes to finance and all that. And then at every point you're expecting approvals. Fortunately, approval doesn't and release doesn't even translate into cash backing. That is one issue. There can be a disconnect at every point I have mentioned now. And there's an issue also around liquidity, availability of funds. You understand? Sometimes you actually get your approval, you get even your release, but cash backing becomes an issue. However, the good news is that we're getting reports that the Kaduna State Revenue Service are reporting an increased internet-generated revenue. So we're hoping that moving forward, we'll see some improvement in that. But like I said, the process are layered and you could get disruption at any point. Thank you.
Thank you so much. So a multi-layered problem requires multi-layered solutions. So I will come to you, sir, the Permanent Secretary of the Ministry of Finance, Habib Aliyu Lawal, sir. So we've heard from the health sector, we've heard from Kachma, we've heard from the Primary Healthcare Board. While they acknowledge that the issues are multi-layered and there could be bottlenecks at any level. So a budget officer might not know how to plan, might not know how to, put together a budget proposal. But at your level at the Ministry of Finance, what would you say the challenge is with ensuring that there is cash backing and the funds are released in a timely manner? What would you say those challenges are at the Ministry of Finance's level?
Well, my fellow participants, ladies and gentlemen, good morning. This issue that centered around cash or financial transactions that took place across our MDAs, that is, ministries, agencies, and parastatals. Well, I may not deny such kind of challenges happening before the coming of this administration. I could remember from the first contract awarded by this present administration, a policy was adopted that right from the beginning in the budgetary provision that there should be a realistic budget. We always work hands in hand and in collaboration with the ministry or with the Commission of Planning and Budget. They try to streamline all budget issues to center in such a way that there will be no redundant funds. There will be no such kind of making budget without effective financing from the government. So His Excellency adopted a model that once a contract, not only in health, across the sectors, if genuinely awarded and successfully completed, that project will attract government approval for payments and at the same time subsequent cash backing. Not only that, right now, I'm telling you, it's not politics. It's what is exactly going on, even on paper. That most of the projects going on in the state, including upgrading of primary healthcare centers that we have, 255 across the state, 142 successfully completed, almost 90 now about to for the second phase. Even the upgrading and renovations of many health institutions, including general hospitals in Kapanchan, in Giwa, in whatever, there are many places. In most cases, and advance payments were made, even before the start of the contract. I am telling you this. In most cases, sometimes it can be 50%, it can be even more, depending on how serious is the contractor. And up to now, any moment you see approval or release, there must be available cash backing. I'm telling you this. But issues with finance is a continuous, because we always demand for money. Not only demanding for money, we demand always for more money to do more and more things. So I hope my colleagues, wherever there are any little difficulties, let's join our hands together. We work together. Let's find the areas so that we call the attention of His Excellency, at least for the improvements in the health sector across our state. Thank you.
Thank you very much. I felt it when you said this is not politics. This is me telling you. I like that you have put your personal intent and integrity on the line in answering that. But I think what you're saying essentially is that with the advent of the new administration, approvals are made with cash backing. So if the Ministry of Finance is saying that approvals are typically made with cash backing, but then the health sector is saying that sometimes funds are not released and they don't quite get to where they need to get to, then I think one of the things we need to achieve in this dialogue is finding out where the actual bottlenecks are, what the exact problems are, so that solutions to fix those could be proposed. I will come back to you, sir. I think I have a few follow-up questions for you. One of my questions, for example, would be, so for 2025, for example, how have releases gone? That's a question you could answer. It's a question the Kachma and the Primary Healthcare Board could answer in terms of what memos have gone out, which ones have been approved, which ones have, releases been made for. That could be a very good acid test of whether there is actually cash backing. But I'll come back to you, sir. I wanted to go to the Permanent Secretary of the Budget and Planning Commission. So your commission is responsible for budget performance and tracking and making sure that after you have developed the budget, you've allocated funding to all of the different MDAs, that those monies, so the Ministry of Finance then disburses the monies, you track how the monies, where the monies go, how they are utilized and all. What would you say are some of the challenges or some of the findings you've had with deciphering where the actual bottlenecks are in terms of budget performance, in terms of releases, timely releases, and the utilization of those funds as well?
Thank you very much. I think what I want to say here is that the primary objective of any government is to provide public goods and services to its citizens. This administration has that objective. But I'm not talking about only the administration, I'm talking about a system. So trying to look at the challenges, bedeviling the financing of health care delivery in the state. Now, the kind of objective of the administration is to provide the necessary services at the health sector generally for the betterment of citizens. And first of all, as a planning commission, what you do is planning. We do plan, and it's a consistent plan that we've been doing. We have the state run plan consistently from the past decade. And then after the planning, we also do budgeting. In the budgeting, the policy of budget is for health sector to have 15%. Like you said rightly, we've been consistently making sure that 15% of the budget of Kaduna State is being realized. That has been sustained. However, we have some barriers, to that respect. The first one is the cash flow challenges. You cannot solve the problem of all the sectors with your little funds available to you. But what you are looking at is what are the issues? Apart from cash flow challenges, we also have bureaucratic bottlenecks. From this table to that table, from that to that, and then this has gone through so many issues that we may be able to realize what you're really looking for. And the most important challenge that I need to discuss is prioritization. I think the health sector generally, the Minister of Health, the Primary Healthcare Agency, and all its related sector, we need to prioritize our healthcare delivery needs. If we don't do that, then we end up getting funding for other part of the sector than real issues that will be addressed. My colleague had just said something to do with that priority. I think it's very important. And we also have what we normally do, what you call MTEF, medium-term expenditure framework, which inform the budget. So if we are following that MTEF religiously, then of course we'll be able to prioritize our health care delivery needs. But oftentimes the MTEF is not really being realized. We go out of that because of lack of prioritization. This is because of what? The capacity of the personnel to do this budgeting, and of course the cash planning from the Ministry of Finance. That's what we call the limited capacity, staff capacity. However, government have been trying, especially this administration, when it comes, whenever you receive an approval, then of course, you'll be rest assured that you get cash backing from the Ministry of Finance. Ours is when we receive approval from the government, of course, we immediately pass it through the Ministry of Finance, and then you get cash backing. But the issue is, how do you articulate your needs based on prioritization? So that's another point that we need to also look at. Well, I tried to bring out some of the steps that we need to take in solving those kind of issues. One is the prioritization of health sector specific needs. And then the other one is identification of gaps in the critical need of government attention. The other time we went on one of the partners to identify gaps in the health sector. So those gaps that we identified, if they will be translated into our operational plans and then put it into a request from government, I think we'll be able to solve some of the problems that we're facing in terms of financing health gaps. You talked about monitoring the expenditure or tracking expenditure. What we're doing is that we are working with civil society organizations, especially we have what we call, we establish a mutual accountability mechanism in the state, where our stakeholders, not in the government, will also look at what the government are doing, advise the government, and then ensure that they follow the government expenditure to the beneficiaries. So this is another tracking that we normally do so that we encourage value for money. And then this development usually enhance commitment, transparency, and accountability in the health service delivery. We have a partner called CADMAM. I know I've been working with them, and then they have been helpful, of course, in tracking the expenditure of government in health sector. And then by the time we receive their report, is what we normally use in report to government. This is exactly what is happening around this. So the government can know exactly whether the approval they are giving in this particular area of sector is achieving result or not. And then we take some little corrections. And then we need to also strengthen the role of our citizens through the open government partnership that we have subscribed to in the state. Kaduna is one of the, it's only the subnational government that subscribe to open government partnership, where we involve all our partners in the state to work together, plan together, and even budget together. And then they also help us in tracking the performance of the budget at intervals. They help us in packaging the report and making some corrections where we have little issues. These are the issues we need to strengthen if you really want to get things done in the health sector, not the health sector, all the other sectors. There's something also that we are doing and we need to strengthen. It's one of the tracking that we're doing, deploying an integrated electronic financial management system for real-time tracking, example, the EMR. We are looking for money. Without money, you cannot be able to finance this project. And then how do you block leakages? One of the examples is through the EMR that we have. EMR can be deployed and can be used in tracking and blocking leakages so that we can be able to get more funds and then link it to other sectors or the health sector to improve other areas of needs. And as a coordinating agency, we do quarterly interagency meeting. If you take health, for example, we bring health ministry and all its agencies. We discuss about the budget, about their plans. What are the issues? What are the challenges? We also need to strengthen that so that through that avenue, we can be able to understand what are the issues there. And then we can make corrections thereafter. Because you also said that we have a lot of partners in the state that are supporting health. But the issue, one issue is that we need to also bring them together and coordinate their support so that we can achieve optimum result of where they are supporting the health sector. Some of the coordination role that we've been doing have begun to yield some results. For example, the last 3 or 4 months, through our coordination, we're able to secure approval of His Excellency in the sum of 400 million naira to counter-fund what the UNICEF will give us in trying to address the issues around malnutrition in the state. So this is one of the reasons. That coordination is very important, is key to addressing some of these challenges. He talked about renovation of 255 PSCs across the state. I think that's also good, and access, that will provide access, but we're looking for the quality and then tracking of what they're doing to really monitor and track, progress and challenges. One thing, the last one I want to say in this is cash planning. Cash planning is very important. That's for the Minister of Finance.
Yeah.
We need to cash plan our request. And then while the Minister of Health will prioritize their needs, and then the Minister of Finance will also plan their cash to be able to finance some of these areas. So I think all these things fall around capacity of even our personnel to be able to do all these things effectively. So briefly, let me just stop here. And then these are the issues I want to talk about: financing, health sector, and tracking the result state.
Thank you so much. Thank you for sharing those thoughts. Those are excellent thoughts. You spoke about the need for partnership coordination, for the need to strengthening coordination mechanisms and platforms like the quarterly interagency meetings that you mentioned. You also spoke about the role of civil society and the role that CADMAM has been playing and the open government partnerships that Kaduna State is currently implementing. I think those are and of course, the need for capacity building. Capacity building keeps coming up quite a bit. And that brings me to you, Dr. Dusi. I'd like you to speak to what the Kaduna State Primary Healthcare Board specifically is doing in terms of mitigating the challenges that you're having with bottlenecks and making sure that when the Ministry of Finance approves funding and releases those funds, that they actually translate to improved service delivery at PHCs. What are the challenges you're encountering with that, and how are you mitigating them?
Yeah, basically, we start from developing our plan. Now, our plans are actually informed by analysis we've done. So they are needs-based. And developing our annual operational plans are actually participatory. We bring in different stakeholders. the different MDAs under the health sector, because we do a sector plan. Now we bring in officers from the MDAs, we bring in our partners, we bring in civil society organizations, we bring in even some representation from the community, like our WDCs, and so it's very, very participatory. That in itself, it's puts in some form of accountability to our expenditure because it is participatory, multifaceted. Even the process of implementation actually goes along that route because there are different stakeholders involved in the implementation. Now that means you don't just go off the tangent and just do what you feel like doing. So it's actually then we have process put in place. We have our monitoring framework developed alongside our plan. So as you are implementing, it is expected that you have actually identified indicators that will show whether you have actually achieved what you have planned. And we periodically assess those performance every day. And the permanent secretary, planner and budget commission said, Kaduna State is one of the states that actually operates the open partnerships. And we have periodic engagement. I will mention Cadman again, that actually come in to do some form of budget analysis periodically. I think it's quarterly. And then we do the open Kaduna. I think Kaduna State is one of the states that it does this, where we open our books, civil society organizations come in, analyze our budget performance, and then we come in, stakeholders are involved, the media are involved, and we table in what we have done and how we have performed so far. Now, one of the issues that we have might not really be the availability of funds. One of the challenges we're having, and I'm happy that the second session will hover around human resource, because now you got the funds, you have the facility, you have the equipment, you have the commodities, the drugs, but human resource sometimes is our issue, and we are actively working around that. Then we have processes also of internal and external auditing within the system that we do. We audit ourselves, and then we engage external auditors to also come and audit us. And we do that. We do our performance review, annual performance review, quarterly, mid-term, and then the end-term performance review. So it's multifaceted. Like I said, we have several layers of accountability frameworks that we've put in place to actually check that what we planned and what we budgeted for are actually being done. Thank you.
Yes, just one quick follow-up question. That would be, what would you say the utilization rates are? So when funds are allocated and you receive them from the Ministry of Finance, how effective is utilization of those funds at primary healthcare level? And how would you strengthen that?
When we do receive the funds, utilization rate, I would say, is 100% utilization, not receiving. But when we do receive, utilization is 100.
Thank you very much for answering that question. So I'll come to you, Madam Abubakar. And I would like you to speak more, because this panel, I know we're almost out of time, but this panel is also about sustainable financing, right? And there's something the Primary Secretary of the Budget and Planning Commission mentioned that I would like to circle back on if I have time, about partnership coordination and all of these other funding sources. So for BHCPF, for the Basic Healthcare Provision Fund in Kaduna State, how instrumental has that been in terms of ensuring sustainable financing for service delivery at primary healthcare centers? And what are the gaps that you've identified? Could be ensuring that the pot is full, could be the same thing we've been talking about, releases, cash backing, whatever it is. How are you leveraging these different funding points to make sure that there's money?
Okay. For the Basic Healthcare Provision Fund, it is one other sort of funding for the vulnerable program in the state. And I will say categorically clear that in the last few years of the implementation of this program, funding has never stopped from the Basic Healthcare Provision Fund. But these fundings are for what anyway? They are meant to ensure that we expand coverage and ensure that equity in terms of access is provided for the most vulnerable population in the state. In terms of service delivery, with the funding from the federal government through the Basic Healthcare Provision Fund, we've been able to ensure that we check on the quality. Quality meaning because the component of it is about ensuring that we have essential drug or essential medicine at those facilities. But again, ensuring that we enroll, looking at the quality of service delivery isn't just enough at the same time, without you also following up to see that data in terms of utilization is also what or put through. Why are we expected to do that? We're expected to do that because, one, we want to also understand what is the disease prevalence as far as those who are enrolled are concerned. So data becomes very key as far as the funding for Basic Healthcare Provision Fund is concerned. And I will also say that part of what is also critical in terms of administering the Basic Healthcare Provision Fund is our ability, as for example, shares like Kaduna State, to be able to report the implementation of this funding from the federal government. But I will tell you that in the administration of the funding, for example, for Basic Healthcare Provision Fund, what we have in the state made critical is our own internal restructuring mechanism for expenditures that we incur. Day in, day out, as you implement at community level, you're bound to experience reasons why expansion, for example, utilization, for example, becomes a major critical issue. For example, the pregnant women in communities are part of those we target under the Basic Healthcare Provision Fund. But you will enroll a woman, you may not see utilization in terms of ANC. You enroll a woman, at the end of the day, you don't see her come to deliver at the facility. So year in, year out, when you see some of these challenges, you devise other strategies that will ensure that you get value for the money that comes through. So for the Kaduna State Contributory Scheme now, we're coming up with a strategy which is a completely community-based tracking platform, which allows us to utilize our community volunteers for tracking of the utilization of these services that we have already procured through the pregnant women. So what that means is that we've trained already here in the state, but we are going beyond the training, also lead these community volunteers in some of our most impacted communities or local governments in Kaduna State, because we want to be able to track, we want to be able to report this utilization. But by and large, it is not all about that also. We want to ensure that at the end of the day, the communities own this program. Owning meaning that they understand the support that comes from government as a responsibility of governance on them as a government, but also to also let them understand that programs such as this also they have responsibilities as a community to commit to the success of these programs as they come into their communities. Because where they don't own it, you will continue to see women who will be pregnant and then don't go for ANCs, don't go for deliveries, and our numbers for our mortalities keep rising. But in terms of assessment of this program, I will tell you, I agree, this can be scored beyond average to a good to say that yes, the implementation of the Basic Healthcare Provision Fund in Kaduna State has actually succeeded in helping us to be able to drive the numbers that we're looking for to do. But if you're looking to say whether we are at 100% or there is room for improvement, I will tell you yes, there is room for improvement. There is a need for us to do much more. There is a need for us to go out there to sensitize more. There is a need for us to change our modes of communication and the language and how we communicate with communities. I can tell you that, yes. So all of this, we will continue. But the biggest impact that we have gotten this year is that from the government, where the government of the day has made a significant contribution in terms of counterpart funding for the basic healthcare provision fund, where today additional 5,000 enrollees have been brought into the fold through what the governor has approved for us to be able to do this. And more than 50% of that contribution is looking towards our maternal mortality index at the local governments that have been most impacted in the state. So there is the federal government through the basic healthcare provision fund coming in to play its role. There is also the state government complementing that particular role in Kaduna State. And because the federal government has come in, because the state government has also been able to do that, we're beginning to see the activities of other levels of governance. For example, the parliament also looking to consider how do they bring this into issues around constituency projects, include that of health. We're also beginning to see the local governments now coming to look at it as a major item to contribute, to complement what all of this change around supporting the vulnerable population in Kaduna State, be able to have access, or let me say equitable access to healthcare in Kaduna State. So it's laudable that we are doing this in the state. And what is more important for me is the fact that we are all not sitting, we're doing it. But beyond all of this, I will tell you, we have partners that are now coming in, support, direct involvement in the area of ensuring that they contribute to getting more women into the scheme to complement what the government is doing. The Clinton Health Access Initiative has done so well with us. Today, we can account for over 25,000 additional enrollees, which centers more around our women who are pregnant, as well as our children in Kaduna State. And then we're looking to have more of these partnerships coming, because this is the only avenue through which we can actually bridge the gap in terms of barriers around equitable access to healthcare in Kaduna State.
Wow, thank you so much. Thank you for sharing those thoughts on the implementation of BHCPF in the States, and thank you for acknowledging the contributions of all the other different parties, the parliaments, the partners. I think that's amazing. And that brings me to my final question, which would be for you, Madam Habib, and you, Madam Bashir, and it's about innovative financing. You had two of the most important commissions in the state that can make or break financing for healthcare. So what are your thoughts on how to ensure sustainable financing in terms of other kinds of financial models? So like public-private partnerships, for example, better partnership coordination with the development partners. Just share your thoughts in a quick 1 minute, how Kaduna State can better mobilize resources, leverage innovative financing models for primary healthcare delivery in the States. You then, Madam Bashir, will go.
Wow. Ladies and gentlemen, I think as I was only having the opportunity to talk or to comment only for 1 minute. I will only say this sustainable financing in the primary healthcare will require multifaceted approach, because there are different ways. In fact, we have seen how effective in making or reaching an adequate agreed budgetary level for our health sectors, or allocation, budget allocation that will ensure the health sector is being taken care of properly. And at the same time, our development partners across the world, I could remember even the day before yesterday, the country director for the World Bank was in Kaduna with His Excellency, trying to give the World Bank courage and motivation to continue to assist Kaduna State in critical areas such as education, primary healthcare areas, and other critical areas that need attention in the state and need more financing. Apart from this, you know, our community partnership involvement in health sector need also to be reinvigorated so that our members of the community, there are some that are well-to-do, just as they are making contribution in education, building schools, furniture, and other things. They assume maybe if you build a school, that's why you will get reward in most cases. But we can create awareness to them that if you build a hospital or a primary healthcare center, or if you buy drugs, equip a hospital with whatever is needed there, including drugs, is just like, consider that you are saving life. Your reward is as much as even more than somebody that even builds school. Just encourage them, motivate them. There are a lot of reports where primary healthcare centers are being built across our communities that they were even abandoned. I'm sorry to say this. I told you it's not a politics. It's a true situation. Why they abandoned the place? Maybe there are no medical personnel to run the place. Maybe the medical equipment to make the place functional is not there. So if we can encourage our rich people in our communities, they can put some little level of finances there, that the system will be improving gradually.
Yes.
At least I think for 1 minute, I'm okay.
Thank you very much. Thank you. That was more like 3 minutes, but it was time well spent. Thank you so much, sir. Before you go, sir, I think I sense that everyone wants to touch on sustainable financing a bit. Am I correct? So if you could please do it in 1 minute, because we're completely out of time, that would be great. Can we have Madam Bashir before you, sir? Yeah, and then.
Thank you. You were still talking about sustainable financing. First of all, like I said earlier, we need to identify the gaps, the critical needs. That's why you understand where you're going to. And then that's why you will spend your money and get value out of it. And then you need to prioritize, which is very important. The bigger amount you have, if you don't prioritize them, of course, you'll not be able to get really what you want in the sector. And then, of course, like I said, the cash planning. We need to have this kind of training. It's like chain from the Ministry of Health or health sector. You understand? Once an approval is gotten, to plan and budget commission, to finance, we all have responsibilities, all have some work to do in trying to achieve the health financing. So prioritization and cash planning is key, it's very important. And we need training in that. And
Any
most
thoughts on
importantly, again, budget
innovation?
performance tracking. That's where we found our challenges and address those challenges in the future. And we also need to be involving our CSOs. Like I said, the OGP and all whatnot, they're all here. And I saw their faces and I saw what they're doing. I know what they're doing. So what they're doing is that, oh, thank God, the OGP guy is here. I don't even know. What they're doing is that they are like watching what the government is doing and then reporting successes and, of course, reporting challenges and bringing out some recommendations so our government will address those challenges. We can get a better result by the time we get and we need to also create more sources of financing, because what we are looking for in the health sector is enormous. The mega amount we have cannot be able to solve the problem of our health sector generally. So by expanding sources, we'll be able to address more other health needs in the state.
Thank you very much for those thoughts, sir.
Okay, thank you very much. Sustainable health financing is sure way to guarantee this equity we're looking and the quality of service we really want to see. It will interest all of us sitting here to know that the report show that out-of-pocket expense has gone beyond 87% today. What does that truly mean? When the actualization was done about 5 years ago in Kaduna, the ability to pay stood at 6,000 naira. So if you look at it as 6,000 naira a day, and you're looking at 87%, we're looking at over 69 billion naira that is out there as out of pocket, which is far, far, far bigger than whatever we are committing, because what the people pay is the major source of health financing, beyond what the government is going to be committing, beyond what the partners are going to be committing. Out of pocket, what the informal sector will drive is the biggest chunk of what needs to come in. So what we need to do majorly will be around how do we coordinate ourselves, put up a structure that allows us to be able to tap in, look at where these are coming from, and how we can get them into what we call the strategic purchasing alignment framework. That allows us to be able to put these resources, like finance is saying, getting, for example, our philanthropists to come in and contribute to that. For us in Kachma, for example, in Kaduna State, we're going to aggressively be working with the World Development Committee people. Because for what? They are the closest. So we want to go to the communities. We want to go to the communities because a lot of our people, they may know that there is this scheme in Kaduna State, but understanding the importance of being in it and the consequences of not getting into it is something that we need to really have to be able to do again as a system. Data and data. We must begin to improve how we ensure that we tap into our data sources. I will tell you, duplication has been a major reason why we waste resources. Until we're able to fine-tune these sources and we're able to structure how we ensure that data comes in, these duplications will continue to waste our resources. So we're looking to see how an individual, a child who is accessing a care, does not replicate in all the other levels of care. How a mother who is accessing care in this particular program allows others to come in instead of duplicating that mother in so many other places. But majorly, again, internal restructuring, like my brother from budget and planning will say, cash planning. We need to also internally restructure our expenditure. We need to be sure that we understand where to put our monies and when we need to put those our monies and what we need to put those our monies for. These are some of those innovative approaches that I believe if we follow through, we should be able to reduce some of these challenges to sustainable financing.
All right, thank you so much. We're completely out of time. Did you have a thought on, can we just, I'm speaking to Dr. Dusi. Are we final? 1 minute, sir. And yes. I really mean 1 minute this time.
I'll try to stay within a minute. What I wanted to just say is that the government already have intervention for alternative source of financing. We've been mentioning the Basic Healthcare Provision Fund. There's the Impact Project. Also, Kaduna State is one of the most blessed states when it comes to partners in states that have actually also been supporting the state. We have been also exploiting some form of PPPs, corporate social responsibility. And then we also have the State Health Insurance Agency. That's also an alternative source of reducing out-of-pocket expenditure. Then the AOP finally, that we are now doing, the federal government move, the sector-wide approach is a very viable way for us to actually get alternative form of funding. We are just praying that approach succeed.
Thank you very much. Thank you so much. We are completely out of time, but we've heard so much about the need for capacity building, prioritization of resources, identifying gaps, working with CSOs for the open budget partnerships, for example, the need for cash planning and having realistic budgets as well, leveraging data and digital. I think that came out from both the Budget and Planning Commission Permanent Secretary and the Kachma DG as well. And then the role of the informal sector. I really like that you snuck that in at the end because it's so critical. There's a vast amount of resources that the informal sector could provide in the health sector, but they are largely uncovered in health insurance, and a lot of monies could come from there. And then partnership coordination, harnessing resources from all of the partners, development partners, public-private partnerships, very important. And finally, from you, Dr. Duse, SWAP is an opportunity for bridging all of these gaps, ensuring that budgets are aligned with gaps that are identified, annual operational planning, and also leveraging the SWAP structure. And, you know, that whole coordination at the national level of resources as well could be leveraged at the subnational level. Unfortunately, we can't take questions now, but if you're not in a hurry, we will take questions after the second panel. We're trying to be mindful of our speakers' time. So thank you so much. Thank you, everyone. We're going to take a very quick group picture, and then we'll go immediately to the second panel.
All right, please, another round of applause again for our esteemed panelists. That was a very, very enlightening conversations that we just had. At this point in time, I will be calling on Safia Tribal Isa again, who is the moderator for the second panel. Please, a round of applause as she takes the stage. Thank you. Thank you very much.
Good morning. And, we are in a bit to accommodate our very busy schedules, so we're not taking any breaks. We're moving straight into the second panel. And I have the privilege of inviting the Permanent Secretary, Ministry of Health. Please come up as the first panelist. Aisha to Abubakar Sadiq. Secondly, I would like to invite Mr. Maxwell Sanda, the Director, Human Resource for Health, State Primary Healthcare Board. Thirdly, I'd like to invite Dr. Kabiru Atta, Country Representative and Gender Health. My big boss and convener, Dr. Anthony Shamang, the McKinsey consultant for Kaduna State. Please come. These are my distinguished panelists, and we will be discussing the very important topic of human resource for health, ensuring availability and equity, especially distribution in hard to reach and remote areas. So permit me, let me take my seat. Distinguished panelists, as we've heard even from the first panel that was talking about financing, the issue of work availability and distribution came up clearly. So I'll start with you, Honorable PS, Ministry of Health. When you spoke this morning, you told us from the policy angle, what is available, and we need a mic, please. What is available and what the state government is doing to mitigate this gap that currently exists. So I'd like to hear more in terms of specifically, when is this rolling out? What is the number that we're looking at? And just, what is the expectation? You have an idea of what the expectation is, especially. Could you just speak clearly to those? Thank you.
Thank you for your question. The Human Resource for Health Policy for the state has a vision of achieving an appropriate number, skilled mix, and distribution of healthcare workers across the state. Because the problem we realize is not just that we have inadequate numbers, but even based on the specialty, we have an inadequate distribution of the specialties. There are areas like neonatology, where you hardly have nurses who are specialized in that. You hardly have medical doctors who are specialist neonatologists. You have an inadequate number of oncologists, or none at all, most centers. When you come to the primary healthcare center, we have a problem with the distribution of midwives. It's cute. We have more nurses than midwives, and then we have a high maternal mortality rate. So we actually need more midwives to address that problem than nurses. So the entire point is to correct those gaps. Now, you talked about numbers. We did a gap assessment, the state, to assess the gaps at the primary healthcare level for human resource for health and the secondary healthcare level. The last time we did it, we needed a minimum of 4 times as many nurses as we have in Kaduna State to actually plot that gap. I'll get you the specific numbers from the Director of Planning later because it keeps on changing. Today you have a 2,000 and this, and tomorrow it's another number. And then you need a minimum of 2 to 3 times as many doctors to handle the human resource for health gap. But because of recurrent attrition in and outside the state, because of those we lose from retirement, those who die out, the numbers have continued to shift. Now, the second part of your question was how soon will that come to pass? How soon will it come to fruition? His Excellency, the Governor, has actually declared that recruitment is to commence. The only issue is, when it comes to government, there are specific bureaucratic processes. You don't just wake up the next morning and say, ladies and gentlemen, submit your applications, we're going to start. So presently, we're in the process of having it go through the head of service, be assessed by the Civil Service Commission, so that they can look at the exact number we need, look at the budget, the funds available in the state. A major problem we encountered is that remuneration is it's the highest reason, most prevalent reason for our loss of staff in the state. The price, the cost, I tell people that it's not a living wage. Yes, you're paid, but it's not a living wage. You cannot survive on that wage. So because of that, the last time we attempted to recruit staff in Kaduna State healthcare workers, the turnout was dismal. Everybody would ask the same question: has the salary changed? And if the salary has not changed, why am I coming to work in the state? So that is another reason we're insisting that the state assesses the funds available and ensures that they can provide a competitive remuneration package before you recruit. Because if you call for interviews and you employ people and you post them and they work for 1 or 2 weeks, I mean, that's just a waste of time. You're back to where you started. So those processes are taking place. And as soon as possible, as soon as the bureaucratic delays are done, we are ready to start screening, call for applications, start screening, and employ individuals. Because everybody is willing to receive them. The centers and the tertiary facilities are ready to have.
Thank you, Honorable PS. That is, I think that's a bit of good news, something to look forward to. And I mean, it's, I will come back to ask if it is close to the 4 times we need, but let me come to Mr. Maxwell, and it is still related to this, taking from what the PS has shared with us. So this recruitment and retention, how are we factoring in our hard to reach and remote areas? Is this a factor in terms of this recruitment process?
Yes, thank you, Sophie, and everyone here. delighted to have the privilege to speak to those whom we provide primary healthcare services. The leadership of the Assembly represented here, our executive arms, and then the CSOs. Of course, our development partners who have been to the question fact. One, yes, there is inequitable distribution of manpower. That is very correct. You know, is the problem there? What are we doing, or what have we done? What are the opportunities, and what are the impact? Because everything revolving around human resource, if it doesn't translate to, improved service provision or people having access, it will be a problem. First and foremost, we have 1,105 facilities that are primary health care in the state, out of which 255 have been earmarked as the focal center. And we would require $16,400. You wouldn't be surprised to hear that the distribution of manpower will be skewed. There are hard-to-reach areas. What we had to do, people like Kachma, Basic Healthcare Provision Funds, had to provide some standard for people, for facilities to get enrolled or get qualified to access additional funds to improve service. So there is a minimum number of staff that are required to be in a center to have such access. So we had to pull them from those other facilities to now meet the requirements. And of course, the 255 are, distributed within the 255 wards of the state. So we see it as a good opportunity for people to come in. What we want to do, based on what the permanent secretary had mentioned, which is now an opportunity, the Hope Gov project, has given Kaduna State the opportunity to engage 1,800. And fortunately for us, His Excellency the Governor has granted approval for the recruitment of 1,800 primary healthcare personnel. I must commend this government. I think from inception to date, we are all crying out, looking at the gap, but a sum of about 11.2 billion naira has been spent on payment of salaries of primary healthcare workers from inception of this administration to date. It looks like a large sum of money, which it actually is, but we still need more to see how we can make this gap, be bridged. Now, with this approval of the governor, the Primary Healthcare Board, under the leadership of the State Ministry of Health, has decided that, look, we are going to make, when we are going to advertise, it has to be vacancy focused, so that those areas that lack manpower, if you are going to apply on the portal, you will tell us where you want to serve. Now, tapping on this opportunity, we hope to see that a form of funding will be negotiated, so that if you are recruited and those are the facilities you intend to serve, you have to spend a minimum of 3 years there before you start requesting for posting. And before those 3 years elapse, of course, we are hoping that another recruitment would have occurred where we'll plug those gaps where you will be pulling out from. And what will be the impact of this 1,800? It will now jack up our staff strength from 32% to 42%, which is also a plus. Data has shown that there is a correlation between availability of manpower and the mortality, the high mortality rate. Now, if these people are engaged and try to address this maldistribution, which you have just spoken about, so us that government is making very honest efforts to see how, this can be ameliorated. Thank you.
Thank you very much, Maxwell. Another piece of good news. But before I move on from this conversation, just to ask, are we considering, are we adding the element of midwives in this targeted recruitment? Because as the PS has mentioned, there is the gap in terms of specialization, the availability of these specific skills. So are we prioritizing midwives in this recruitment?
Yes, we are prioritizing midwife. Just to give a clearer picture, we require 2,272 midwives, but at the moment we only have 500. So it means we need all the midwives we can get to, beat down the maternal child mortality.
Thank you very much. All right.
I just want to add 3 points to the issue of the rural-urban distribution gap. What we observe is that when it comes to rural posting, nobody is willing to go. And even those who are posted to rural community do not want to stay. Because just before I came up, I got a message from another permanent secretary telling me her relation wants to leave the village. She's posted to come back properly. So some of the measures we've actually looked at and actually brought out in the Human Resource for Health Policy and implementation plan and the strategy is to ensure that there are additional allowance for rural postings. Formally, there were allowances for rural postings, but they never came to fruition. So you will be posted, but you will never get the allowance. Yeah, I think it was 5,000 naira. I mean, really, what difference does that really make? So it's to scale up, that was to review or revise upwards the rural allowance and ensure that they are paid. Second, the upgrades we are having to our health facilities, including our primary health care. I know there is a standardized model that includes accommodation for staff, particularly clinical staff, because I've actually seen the architect model and I've seen the schematic, and there is supposed to be comfortable, habitable accommodation attached to the facilities once they're upgraded. Now, we all know about the cost of living. By the time somebody eliminates the cost of accommodation for you, I mean, why not? Why stay in the city and pay accommodation if you can live for free in the rural communities and still do your job? The third measure we have is awards and additional incentives. I remember being younger in Kaduna State and people would be awarded annually for the best performer or, best admin staff or best nurse or best performing medical doctor. Somehow that was phased out. We are trying to ensure, we even have it, not we are trying, we intend to ensure that it's brought back so that you are rewarded for your performance. Any nurse or medical doctor that is willing to go to this rural community and can save life and stay there and do their job, they require some form of maybe travel opportunities for trainings within the country, sometimes cash prize. I remember in the old days, some people got land for doing very well. You were given land in the village where you work, partnership with the traditional rulers. They'll give you a plot of land to farm. That's welcome. Thank
you, PS, for that additional clarity. And you have sort of like linked us to what it means to motivate, what it means to even have best practice for how to retain and recruit our health workforce. The gap is there, but baby steps are being taken. I'll probably come back to say how soon. And Kadmam is here as well in terms of tracking this good news that we're hearing. So Dr. Kabiru, I'm coming to you. And I'd like to speak to you about how, engender health, your work in strengthening healthcare systems and improving reproductive health services specifically. So from your experience, what innovative approaches have been effective addressing this workforce challenge?
So thank you very much, Sophia. So I think I'll kind of flip the question because I'm surrounded in this room by very senior policymakers. And I can almost say there's no innovative approach that I know that you don't know. The permanent secretary mentioned that they just really developed a human resource health policy, which was supported by partners. Everything that has been that's innovative, tax shifting, tax sharing, on the job training, digital transformation, rural health, it's all in that policy. So from my experience, the most important approach is execution. It's not the idea, it's execution. And it's execution from the perspective of the government. We need to realize that Kaduna State is not the human resource for health market is a global market. And Kaduna State is playing in that market. 25 years ago, my late uncle, renowned gynecologist, he was always flying from Abuja to Saudi. But that was at that point, it wasn't called Japan. Almost 30 years ago. So it's not now health workers started to migrate. But what has happened in the last 15 years is technology. So a health worker in PHC Tudunwada on a mobile phone can communicate with a hospital in the UK, understand the criteria, spend the next 1 year, prepare for those criteria, and leave the civil service. So they are using the government as a conduit. It's basically a conduit as well. So even when I hear we want to recruit 1,800 workers, am I excited? Yes, I appreciate the governor's effort. But I come back to what the permanent secretary said, the remuneration. So even within Nigeria, is Kaduna State competing favorably with the neighboring state? In the project we did in Bauchi, they had absolute no doctors in almost 60% of their secondary facilities. Primary healthcare was even worse. Why? Because if they recruit today, the next 2-3 months, people are moving to Gombe and Plateau State. Right? So we had to sit down with the state to say, what can you do? And if you come from a perspective of management, policymakers, managers, they don't like recurrent costs. In fact, if you study business, you reduce your recurrent costs, but are able to maintain production, the value of your company goes up. So nobody likes recurrent costs. The governor did not like recurrent costs in Bauchi, and he felt even if he increased salary for people in Bauchi, health workers in Bauchi, what happened? The teachers want increase. The civil servants, what does he face? A strike action. So we had to work with the Ministry of Health to come up with an innovative allowance, like a top-up, which was really significant for the health workers. And then we realized that suddenly we had health workers in the facility. The second thing we did is that nobody likes stagnation in their career. If you put a health worker in the facility, what is the career path? So we now had to work closely with ATBU in Bauchi to begin to link those health workers in the state civil servants to different career growing programs. If you are a nurse, what programs can you do? If you are a doctor, what program can you do? If you are a CHU, you want to become a nurse, how can we? And that meant that if they get into a program for 3 to 5 years, they will stay for 3 to 5 years, right? They will stay for 3 to 5 years as well. So we need to go kind of understand that we're playing in the global market, and we need to go back to Maslow's theory of hierarchy of needs. What do people want? Self-actualization. Nobody wants to, not all of us wants to become the president or Dangote. We just want to live and enjoy our families and give back to the community. So for me, I think is that if we can begin to work from that principle and drive execution, the Ministry of Finance, the Ministry of Budget, Ministry of Health, the Primary Health Care Board, and put in place the right condition of service, because you are competing with Kano, you are competing with FCT. We were in Lagos recently, and they had doctors in their primary health care facility. Yes, managers, yes. In the primary healthcare facilities in Lagos. So is it impossible to get doctors in PhDs? No. Your condition of service just has to be competitive. So for me, my key message is we have the solution. Like I said, there's nothing I will say to this group that you don't already know. How do we just drive execution? I think that for me is the innovation that we need for. Thank you very much.
Thank you, Dr. Kabiru. Very insightful lessons. And it's so good that we have very key personnel in the room here that can take this forward. And with our voices also, we can show very close, Bauchi, Lagos, this is working. And so it's possible in Kaduna. So I'm going to come to you, Dr. Anthony, because, still in the spirit of learning best practices and what motivates. Dr. Kabiru has shared self-actualization, but I'd like to hear from you also in terms of specific lessons that we can learn from other countries, regions that have successfully tackled primary health care shortage of work.
Yes, you live here. So when I was going to vision, I looked at some of the various lessons that Nigeria can learn. And just like what past speaker Kabiru said, I think our major issue is how to implement some of the lessons, because most of these lessons have kind of is known to us in Nigeria. We have tried it, we have implemented it, but it has not worked. So the major discussion here should be around why has it worked? I give you an instance, one of the lessons. Anyway, we know the major issue facing around workforce, around disparity, which Maxwell has mentioned, urban-rural imbalance. Most people want to work urban. I remember some years back, around 2017 and 2018, the Gates Foundation supported HSDF to a workforce productivity index. And it shows clearly that most of those facilities in the urban areas are not performing. And what's the reason why they are not performing? They're not performing because if you aggregate or you take an index of the load of patients see versus number of, you go to one of any urban PHC here, see 32 health workers. But when you go to the rural area, you hardly will find a health clinic that has 3 or 2 health workers. And the workload for those rural facilities, and that explains why those performance index shows that most of the in the urban areas are non-performing. And I remember one thing we did with the governor when we presented this to the governor then, as a former governor and Minister of Health. Governor gave a directive that should do a redistribution of work health force. That was done. Remember him asking that he wants to sign off, because just like what the PSC, the major issue is the political leader. I have my wife. Why should we send my wife to rural hospital facility? Why should my daughter, or why should my sister, why should my relative? So who wants to go to those rural areas? So these are some of the key issues. It's around, if you look at most of the lessons of what some of these countries have done, both developed and part developing countries, obviously shows that in Nigeria here we have issues implementing some of these models. I give you one, like the community health workers. Some countries like Brazil, India, and Rwanda have scaled up the use of community health workers. Who are community health workers? Community health workers are people that are trusted by community, who have not been formally trained to be medical personnel, but have been trained to provide some kind of light medical services and also create demand. Ask the women to come or the children to come to the person to create demand for this health services. And if you follow history, we have brought, we have politicalized this, because anytime a new ED or a new chief executive of an agency comes, it changes the name and the whole thing changes. So we keep, changing the names of this thing, and that's why we have not really achieved. Just some years back, just last year, we have what we call chief. Now the new ED has come, he has brought in. So what has happened to all the investment, all that has been put into the chief? Now we're trying to bring in a new thing. So I think in Kaduna specific, we have what we call the community volunteers. I think they've been very effective for us. Volunteers, we don't pay them, we don't monetize anything. Go to the communities, they create demand, they ask the women something, and we're seeing results on that. That is just one of it. The second one is the TSTS. We have the policy, we have the policy. Just recently, we're in Abuja, Kaduna State, and I think next also going to Kano again to still develop a work plan. Yes. So why hasn't it worked? I think some of the reason why we should be asked. But we have we've been implementing this TSTS policy, but still hasn't solved key gap, in the work health force. Then we talked about the rural recruitment and training, which I think the TS also. How do we encourage people working in the rural area? So how do we encourage them to stay? That retainership, And I remember also there was a program they called, foundation. I think it was working with the community leaders. I'm sure the BDC. So it's around how do you work with the community leaders to identify someone from their community? Because the issue is nobody wants to go to those rural or hard-to-reach communities to stay to work. So how can the community themselves nominate or bring up? The government is ready to help train this personnel so that when they come back, at least they have their parents there, they have their children there, they have their relatives, so they'll be able to stay there and provide those needed medical services. These are things that have started or we have done, but as if it hasn't worked, has failed. What are the issues? Then we looked at also, there's also telemedicine, even what countries like India and Rwanda, we don't have the personnel to be those persons. How can we create an idea, a method where a media where they can talk to someone? If the Gates Foundation have done that in Kaduna and it worked, I think just that we did it very low scale, just in Kaduna North, created a telemedicine clinic, and particularly during that COVID era where health, restriction movement was a big issue. So we created that and got a partner that came, implemented that, and it worked. But where is it? The next thing is for the state government to scale up that. But that has gone down. So these are some of these models that other countries have used. To have the PAC team-based care, where you have a team-based care that goes to specific community in a combination of various skill sets, go to those community, as just like an outreach, provide this service there. Then we have the bonded service team. Sure, knows about that. I benefited from while I was medical school, I was being bonded. I was getting some, we have director, we have a couple of us here, all doctors from, I think to some extent, even the nurses and the pharmacists, we have been bonded. And the bonding is that when you graduate, you must come back to serve, which we did. I came back, I served for some years. Yes, but I unbonded myself. So these are all models that some countries are using and is working for them. But Kaduna and Sure, not just Kaduna, but when we're in school, we know that most of those northern states. So why hasn't Kaduna up there for some reason? Because the doctors are running away, the healthcare workers are running away. Why? Same reason we've been talking. The welfare, the payment, there's no motivation to even come back and serve because you can't even though you are being born. Some people even agree to pay to unborn themselves just to live. You know? So these are all we've seen that these are things that have worked in some countries like Philippines, like Thailand. So these are some of the key models that have used these countries work. But like I said, not that we are not aware of them or we have not even tried them in Nigeria. We have. But the key reason is why has it worked. I think this is another topic for discussion where we need to
Yes.
we need to unravel all that.
Dr.
Yeah.
Shamal,
Yeah.
you have touched on, a very important point that I'd like just follow on. And, two things have stood out for me since this conversation started. The issue of the remuneration and how perhaps can increase or make it competitive. But there is also an opportunity with the existing structures, which you have just touched on. The community volunteer, which is specific to Kaduna State. And in other states, it was cheap. I think it's moving to community-based workers also now. So, P.S., I mean, it's feel free to, direct me in another lane. But I really want to know, is there a policy perhaps, that is going to ensure the sustainability of this community volunteers, or how do we strengthen it as an opportunity to mitigate this gap that we have?
Well, it's for now, I will say the main policy we have that can be used to sustain them is utilizing the best practices in the human resource for health policy. Because what we realize is the main problem is they might not be on a salary, but they have logistic demands which are not met. Previously, it was easy for them. They were paid, I think, a token. Some of them got tokens from some of the organizations, NGOs. I was speaking to one of them and he said they used to pay him 1,500 or 2,000. I mean, ladies and gentlemen, let's be honest. I mean, 1,500 and 2,000 naira. Can it even get you to the main road? If you are thirsty or you are hungry and you are in a community providing healthcare at community level to a client or a patient, however you want to categorize, can you eat with 1,500 to 2,000 naira? So the idea of expecting them to work for free and just giving them tokens is not feasible and realistic anymore, because the reality on ground in the situation, in the country, in the communities, in their lives, cannot allow them to function effectively with that model. What we have to do is we have to come up with a remuneration package for them. We want to retain them. We can't keep on deluding ourselves and say based on goodwill, somebody will work. Yes, you have the goodwill, but I mean, we've had people pass out. I remember reports I got of some community volunteers that were working with a team, and one of them fainted. And they all ran to resuscitate him and found out that that person had not had breakfast, showed up at work after, I think, water and maybe a biscuit or something, and had walked for hours till late in the afternoon. So the person was hypoglycemic. So how do you work when you can't even move around? That's something we have to look at realistically, go back to the drawing board and come up with a way to compensate them for their service. Now, if you had other incentives too, like integration, the chance, as he said, nobody wants to stagnate. It can eventually be incorporated into the system. Then it makes you dedicated, it makes you want to work. We had a situation in some health facilities in Zaria where community volunteers worked in the community and they were promised that once casual staff or whatever were recruited in the PHC, they will be added to the list based on their performance. They worked tirelessly, and the next thing they woke up one morning and there was a list, and none of them was on the list. It almost became a demonstration. So we need to do better. We have to have a path for them to be integrated into the system so there is a hope for ascension and for transition to a permanent career in the health sector because they are clearly interested. We must remunerate them and we need to acknowledge them, even if it's as a media briefing with the governor or the deputy governor or the traditional rulers. People like to be seen, even if it's also, yeah, this is one of our community volunteers. They've done so well. They work hard and they're left visible. And then they give up and give it.
Yes, you've given us some tips, and I believe my fellow colleagues, CSOs, are here of how we can stage this advocacy to ensure that something is being done about the sustainability, the formalizing of this community volunteers. So, still on that, Mr. Maxwell, just from your seat as the director, is there something else that needs to be done to strengthen this formalization process? Because it is an opportunity, it is a low-hanging fruit.
Yeah, so just to say that one of the communities that permanent secretary and commissioner, in one of our meetings, Daria gave us was to identify serving volunteers. I don't know if you remember that. Yes. So if we are going to recruit, they should be reasonably considered for absorption because it usually demoralizes them. You rightly mentioned it. Some had been promised they're providing voluntary services for 1, 2, 3, up to 15 years. And when we had our last recruitment in 2020, most of them didn't see them. They just saw new people coming in, and they are the ones even teaching the new people. So that has been accommodated, and we have that list now. And the wisdom behind the directive they gave us was when they challenged the Primary Healthcare Board, why are we not engaging these volunteers? We now told them that during the last administration, when we were to recruit, the issue came up. The governing board now said we should obtain list of volunteers. That was when fake names were flying left, right, and center. And what the governing board said was, okay, if they want to go that route, let them compete. Let them go and sit for the aptitude test. If they have been volunteering, providing voluntary service, they should be able to perform better than those who are just coming up from the health training institutions. And we lost a lot of them that way. For this exercise, I'm sure that a certain percentage would be allocated to absorb them. And, once those ones move, those chips too might now fit into where those ones are coming in. So I think to that extent, that is what I can say, because as far as policies are concerned, we rely on the Ministry for Policies. We are implemented. Thank
you. So this is an opportunity for us here on this panel. The four of you, Dr. Anthony has challenged us. Why are our policies not translating into action? So before you leave the stage, I need to hear from you what we can do to take this to the next level. It's an important milestone for this discussion. If we're able to move the needle, just even if it's in one area. So how can we just make sure that whichever part, be it the remuneration, be it the formalizing of this community volunteers, and any other one that we can chase, what can we do to make sure that it moves and translates? I'll start with, and we'll just.
Well, the truth of the matter is just to act on policy. For the remuneration, I am aware, I'm even supposed to be in a meeting where the Ministry of Health invited all the stakeholders in health. They are trying to make another review of an upward review for the salaries of healthcare workers. So that is ongoing. And of course, it's continuous process. It's the process I can't tell you will stop here because the finance man said there is money, but there is always need for more money. So I know that for that, I know the state is making efforts to improve on that. And secondly, on the issue of the volunteers, I tell you, we have a very serious and committed leadership in the Ministry of Health now. They are tracking all the agencies under them to ensure that all these policies are implemented. We always come and engage our expanded management meetings based on those policies. So I'm sure the needle will certainly be moved. Thank you.
So for me, I'll speak on side of we development partners, where the ecosystem of the workspace where I work. So I think we have, let me say, Nigeria and even Kaduna State, among all the other states, blessed with so many partners. So at times, these partners, at times, I think we need to be better coordinated because we need to align with the state's strategic priorities, and we need also to count. So most of the times we might even be the ones even causing the confusion. The states or the federal government might be on this track, and a development partner comes with the huge amount of money, say, no, this is the way you should go. And that strategic shift, shift completely from all that has been achieved. So it's important that we always align, coming into a ecosystem, and you see that this is what has been, this is what is existing, or this is what is going on. I think it's important that you try to see, how you can improve that, and not just bringing in a new, to avoid all that confusion and duplication.
So thank you. For the Ministry of Health, for one thing, for the medical doctors, nurses, it's to ensure that remuneration is based on best practice, based on salary scales and percentages that have been accepted and implemented in other parts of the country. We have the contest, we have the contest, so we need to move. Now, for the volunteers, we're in the process of ensuring that we create a payment for the volunteers that is formalized, so that we have it documented that if you're a volunteer, you provide this specific service, you'll be eligible to this or entitled to this amount of money. If you're a volunteer and this are the number of days you work, even if it's an hourly rate or something, we have to have it documented so they enter into, I say to people, I say what is not documented is not done. It's only in Nigeria that people still have verbal contracts. And you expect the other party to uphold the agreement. Nobody does that anywhere in the world. There's nothing like an ironclad verbal contract. So we need to come up with contracts for these volunteers that clearly itemize the conditions of service. Is that not so? Engagement, survey, dismissal or termination, entitlements, is that not so? Opportunities for growth. We're in the process of designing that. And then lastly, we are in the process of ensuring there is a valid and secure inventory or database of all of them. Because if all their names, maybe you give them unique, but you give them unique identifiers. Is that not so? You have passport photographs of them in a database. It's almost impossible for someone to show up when you are recruiting, as Maxwell said, and out of thin air, abracadabra, you have 10 people answering Amina Mohammed, because you can validate it. That's the entire point of all those checks and mechanisms and biometrics. I mean, biometrics is a bit advanced, but even having passports and giving unique identifiers will help you know, is this the same person who has volunteered on? So those are the best have place now, or rather what we have on the border. We're trying to get them done to ensure that at least they get some of their entitlements for the service provided.
Thank you. So for me, I'll just speak about an event I was in an event last week, and there was the video video clip of a health worker in Plateau State who had been trained on a family planning project. And in the video clip, he said that, and this is in her words, he said, I've been trained by the project, I'm paid my salary regularly, the husband came with the wife because they needed a family planning method. And after counseling, they needed hormonal IUD. We also had hormonal IUD in stock. So I was able to give that to the client. The woman was happy. And 2 weeks later, the husband brought me a gift because he was happy too as well. And by that action, I am happy. You know, and she laid it out very beautifully at the video clip. Client was happy, husband was happy, she was happy. And it took me back to a book I read years back. The Emir of Dubai, Sheikh Al Maktoum, I don't know his full name. In one of his books, it's called Flashes of Thought. And in that book, he tried to document all his engagement with his government officials as the emir. And in one of the chapters, he talked about a government conference, the first government conference he had. And he asked each of his ministers, why are we here? And the Minister of Health, to provide healthcare services, work, provide road. And after they all had spoken, he said that no, the reason we are here is to make Emiratis happy. That singular purpose is that everything you do, you have to benchmark it against whether it is allowing the citizens of Dubai to be happy or not. If you cannot put that benchmark, then he doesn't approve it. And for me, it was such a powerful statement. And so I also reflect back on the event, the budget analysis event we had a few weeks in Kaduna. And you could see clearly that for the last 3 years, the state government has always almost hit 80 to 90%. In fact, in one instance, 90% in terms of paying remuneration. And that, you know, he said almost 11 billion has been spent, right? And then you also look at that budget, you see that in terms of capital project, it's also hitting very high percentages. But the overhead, one time was 4%, another time was 3%, last year was 20%. Now, what does the overhead cover, among other things? It is the engine room of the ministry. The permanent secretary wants to buy paper. The permanent secretary wants to travel. The health workers wants to go on supervision. You know, it's like Kaduna State government has bought a very beautiful car, hired a driver that may or may not be qualified, but it's not paying for the fuel. So how will you get to where you want to get to, right? So for me, my key action I would say is, how do we get the state pay more for the overhead so that the health workers in the facilities have access to these resources? The Ministry of Health, primary health care, they are able to go and support the supportive supervision. You know, so many things that overhead committee. We were talking about trainings. How do we get them to fund these activities? Honestly, for me, and I kept on checking if the permanent secretary, Minister of Finance, unfortunately, was to say, how do we get to fund these things? How do we commit in this hall to say, we did 4% 2022, 3% 2023, 20% last year? Why can't we make it 70%? So for me, that's really my call to action to the policymakers in the state, and really where I think we need to buy fuel to allow the ministry to go. Thank you very much.
Thank you very much. Ladies and gentlemen, we will be drawing the curtain on this panel discussion, but as promised, we will take some quick questions from you. We'll start with questions this panel, and then we will also take questions for the first panel, because we still have some of our panelists here. It's important that we hear. We have very clear call to actions from this panel discussion. And I, for one, am very happy because it makes my work easy when I'm going to engage with the Ministry of Finance, Budget Planning. I know clearly what I'm going to say. When I talk to my colleagues in the development space, I am talking from the lens of let's work together. And I'm so happy that we have Engender Health Budget is also part of this panel discussion. So you can see that we are being mindful of that coordination, making sure that we're not duplicating efforts or causing any distraction. So, okay, yes.
We have a bit of a problem. We have multiple they're waiting. So I want to crave your indulgence, the picture, and then you will sit on my seat. I will take the picture and Dr. Sunday will sit on my seat and answer my question. If he can't answer it, you call me because I have to physically move to another place.
No problem, PS. Thank you very much. So we'll take the picture, please.
Thank you very much. My name is Yusuf Sidin Allah. I work with Life Bank and Board Foundation as government relations lead. My question is actually in view of the last comment made by the Pata, regarding the need for policymakers to up the recurrent expense so as to breach some of these financial challenges, especially at last mile facilities. I'm a finance person and I'm also a logistician. I'm also concerned about what policymakers are actually putting in place to help improve the capacity of some of these healthcare workers in area of financial reporting standard. Because we've had instances where there are misappropriation of funds that are hitherto budgeted for drugs are being misapplied to take care of some hospital administrative convenience. So I would like to know what policies are being put in place to ensure there's no balanced budget anywhere in the world. However, the little that is being able to accrue to these facilities, how well are they utilizing it? And what sort of financial reporting framework are put in place for them to ensure there is accountability and transparent use of these resources? Thank you very much.
We'll just take all the questions. Then
Good afternoon, everyone. My name is Dr. Arubunku, the team lead for Pathfinder International. I have two questions, one for the previous panelist and one for current panel. For the previous panelist, my question was the PS finance, and was a lot of discussions were around issue of cashback, and somehow I don't know if it's only me, but I didn't get the actual reason why there is no cashback in for a lot of program, project, and commodities and so on. 2 years ago, I was Kaduna here, handling the family planning project, and a lot of issues with commodities were raised, and the resultant factor of that issue, the lack of cash backing. So I'm surprised that at this level now, we're still, discussing and struggling with the issue of cash backing, and not tangible 1 or 2 reasons given to why this cash backing is not being implemented. And secondly, for the current panelists, I think the Abiru mentioned it with regards to the overhead. I was really deeply concerned when this data came up with regards to depreciation of the overhead. And as he said, the overhead is the driving mechanism, the fuel we need to move on. So looking at that, it's like the entire budget, even though the performance is around 30-something%, more than 90% of which just goes to salaries and all, and whatever is left over probably is left for the partners in charge. So I believe like a lot has to be done to tackle this. And to add up to the human resource for health challenge, yes, our project, the TSTS project, is here to bridge some of the gaps we're experiencing, where we're aiming at training and building the capacity of Qs and Js, which are the majority of the healthcare workforce now manning the primary health center. And our project, supported by the Gates Foundation, is here to bridge that gap so that we train the Qs and Js on nursing skill and midwives so that they can handle deliveries at facility level. A lot of data has shown with regards to how maternal mortality has increased about 6-fold from the last quarter of last year to this quarter of this year. And so, and we're aiming at reaching that gap. However, we're talking about policy. And yes, it has been mentioned that about 1,100 health workers recruited and priority should be given to the midwives. Now, how can we now design policy that will enable the state to have not just considering the factors that are allowing, testing the health workforce, cover those factors, increase the remuneration, allowances, accommodation, whatever have you. But let's have a policy that is designed that so maybe annually a certain percentage of health workforce will be recruited to bridge that gap. We are far, far behind. We are not even up to 50%, and we are still talking about 1,800. We should be talking about taking 5,000 instead of 1,800.
Thank you,
so
Dr.
much.
Mindful of time, please. Our traditional leader in 30 seconds, please.
Good afternoon. I remain Garbadium, and I'm here not as the traditional leader, but the Secretary General of the World Development Committee, Alliance Kaduna State. The panelists discussed the issue of retention of our healthcare personnel. And, let me tell you before my question that mostly in some cases, it is not a financial incentive that matters. I'm telling you a real life situation. Up until 2023, in my LGA, we had 10 medical personnel in 10 of our wards. One did not have because of security fears that it was we in rural area didn't want to use the doctor. So, but they started living one by one, and the only doctor that sacrificed waited up until that time. One doctor, Olaide Olade. What he wanted was implement equipment for him to be able to function optimally. If we're able to provide this, I think some people out of sheer patriotism still remain business. So now my question is, outside financial inducement, what is government thinking do for all these healthcare staffs? Main with Kaduna because we're not competing everybody. And thank you, Dr. Shamang, for recognizing the beauties. Everybody was OGP. Thank you.
Thank you very much. Mine is a bit information and some question. In one of our meetings with the Executive Secretary of Kaduna State Scholarship and Loans Board, we were engaging him and he was telling us that there are medical doctors, students rather, across the northern tertiary, about 700 of them. So what is the health sector or Minister of Health doing, to engage? We need to bring back that bonding thing so that we can, equip our various facilities with them. That bonding is very important. And of course, I also want to discuss about workforce planning. It is very key. If you are doing it, then you need to strengthen it. If you're not doing it, of course, you need to start doing it. Workforce planning is very important. How do you plan your workforce across the level of healthcare delivery? How many percent do you have that are retiring? What time? What are we doing to recruit more, to replace them? To complement that also, we also need to bring this as a policy. Let's pick those who are serious, those who retire and are still strong staff, so that we can retain them in our facilities. They can be helpful. You go to some facilities, there is only one doctor or one nurse or whatever. So if you retain them for the policy is 2 years contract, we will give them. At least after 2 years, we might have gotten our personnel through recruitment. One other important thing again is to strengthen our employee performance management system, which is very key. Both the secondary facility and the primary facility, we need to strengthen the performance management of our employees at the facilities. Otherwise, if you are not tracking their performance, they will not be doing exactly what you really want them to be doing. This is just my piece of question and comment. Thank you.
Yes. So about 2 or even 3 of these questions are related to finance. And I think perhaps the available panelists from the first question will contribute. But let me start with the one that was directed at you, Dr. Atta. Aliu wants to know how we ensure the efficiency of fund utilization at.
Okay, so I'm aware that right from the federal level, there's been over the last 5, maybe starting from the Saving 1 Million Life program, coming into basic healthcare provision funds. All those programs had specific amounts dedicated to building the capacity of healthcare workers and the healthcare system in financial management, budget management, strengthening your internal control systems within those projects, and even within the specific states. And I think even Kaduna with HSDF and some other partners have actually worked with the primary healthcare board to do financial management training and strengthen those systems as well. But you need to, like I always say, you need to look beyond the training. Even if you train all the health worker on financial management systems, and you are training them to improve their capacity to manage fund utilization, minimize leakages, unless you address the root problems that exist, right? How that training does not make sense. Because, and I don't know the rates for Kaduna, but in Kebbi State, sometime in November, myself and the executive secretary for Kebbi State, we went to a facility in Kebbi State. And I asked the nurse that was there, he was on level 14. I asked her, how much are you being paid? She said she was being paid 50,000 naira. She's on level 14, right? Being paid 50,000 naira. So I turned to the permanent secretary, the executive secretary, and I said, yes, if you are in your house tomorrow and you get a call that this woman has pilfered drugs from this facility, what will be your reaction? Because let's don't rely on patriotism for people to do the right thing. let's put the conditions that are right for them to do the right thing. You understand? So for me, I think that beyond the training that we want to emphasize, even if you put all your internal control process, it just takes collusion to break it. And if you're not empowering everybody along the system, you're not paying them well, you're not working in good conditions, then what's the benefit of that process? And I think just to respond to you about the doctor. So yes, in fact, there are studies that show that salary, it's not among the top 5 things why people stay in job. Your salary, most times, is career progression, job satisfaction, good working environment, right? So, and those are the things we need to really improve, and will get people to stay within the system as well. So I think that would be my response.
Thank you, Dr. Atta. Dr. Sunday, could hold on to the mic. And just, I would direct part of Dr. Argugo's question to you. The issue of, the TS that he mentioned, is this really going to solve or alleviate a bit of the suffering? Personally, I feel laboring the already labored. That's a personal opinion. I'd like to hear from you.
Okay, thank you very much. So I think the tax shifting and tax sharing policy it's just a stopgap. It's not a solution to a problem. It's just a stopgap until we get the right thing done. The problem is when are we getting the right thing done? Because we're talking about skill manpower. Yes. So the skill manpower, we're talking about the nurses, the midwives. So they are not there in sufficient quantity for them to be able to perform the right services that we are expecting them to perform. And we have all enumerated the reasons why. And even when issue of recruitment is not even the issue, because today you will recruit them and they will go. So when are we going to put all the necessary things in place that will be able to employ these health workers and they will stay and do the work is the problem. Until we get there, we will not be able, we'll continue to look for other alternative measures like the tax shifting and the tax sharing. These people are not, they are there to perform certain tax and certain tax, not too technical tax, so that they will now be able to refer to the appropriate place where they will get the right service to be delivered. So that initial process is very key, because if it is not there, at that level, especially the rural level where these staffs are not available, we will continue to have a lot of debt. So they should be able to identify problems, and the ones that are within their capacity, they will be able to address, and then they will be able to make referral to appropriate quotas where they can get the right service. So that is the essence of the tax shifting. So like I say, it's a stopgap. But our worry is, when are we going to phase them out? Because it's becoming a statutory human resource for health. Yes, becoming a statutory. We don't know when we can phase them out, because we don't know when this problem can be resolved. So that's the major challenge.
Thank you, Dr. Sunday. Dr. Shamang, just in response to what the PS Budget and Planning has talked about, planning workforce, any advice?
I think, like in planning the workforce, the government needs to be very transparent and very open. And like I mentioned, some of these issues, some of these challenges are not new to us. There's challenges that are very obvious. Trying to go away from it, not solve the problem. And so the solution to this is to face this head on. We know what challenges, like what Kabir said, The recurrent expenses, most government try to, but running away from it is not so. It's for us to find solution. We made mention of the rural posting allowance, why our health workers not stay. I remember when I joined the service, when eventually I finished my education and returned back to the state. Rural allowance was 5,000 naira. That was like some 25 years ago. Until date, it's still 25. Sorry, still 5,000 naira. Hazard allowance was 3,000 or 5,000 naira 25 years ago. Until date, hazard allowance 5,000. So I think we need to be very. There are very good global practices or what can work for the state. So it's for our policymakers, our political leaders to sit down and really understand some of these dynamics, some of these challenges, and address them. But these are just the way to go. Thank you.
You want to add?
Just to say that FAMSEC planning and budget was highly instrumental to developing the board's corporate plan, and at that time we were able to, introduce human resource division, and we have workforce planning officers, and of course the Hope Gov project, which is still within your purview, has enabled us to make a 5-year plan for this recruitment to plug the entire gap, which the other gentleman behind highlighted, were to recruit 1,800 for a period of 5 years, plug 9,000. Yes, we can be aspirational. We want to recruit 5,000 within a year. We tried it. You recall, sir, when Madam approved 3,059, it was taken to Plan and Budget Commission. They looked at, yes, it was accommodated in that year's budget for both local government and state, but the fiscal space would only allow us to engage 1,225. So, yes, the problem is well acknowledged, but using the human resource for health strategic plan, we have 5 years to plug that gap. We'll plug 9,000. And that will be going side by side with the exits, which are statutory, either by age or by years of service. Death, we don't know. Transfers of service outside, we don't, but we use that for our workforce planning, and we have those figures. And happily enough, I don't need to bother Ministry of Health to review any policy. In the amended law that established the State Primary Health Care Board 2020, there's provision to replace when vacancy occurs. Thank you very much.
Thank you, Mr. Maxwell. I have to allow my distinguished panelists to step down from the stage. They have been amazing and accommodated all our questions. But as a passing thought, I want to say that the fact that we need to review and upward as it is. So I want to pass it back to the Ministry of Budget and Planning. It sounds like we need to do more in terms of the monies that go to health, for overhead, or even the salaries and the running costs. So we need to, it seems we need to allocate more. It seems we need to be more innovative in terms of the funding, the taxation, the sources that can actually fund our health system and make it competitive. So thank you very much. I'd like to invite Dr. Kemisola Abaoye. Oh, my partner. Let you. Dr. Biobele, you have 1 minute to please share with us, because you were supposed to be part of this panel discussion and would like to just give you that opportunity.
Good afternoon, everyone. Good afternoon. I sincerely apologize. There's a lot of conflicting engagements going on in the state. So just to give a brief note on what we do in the state. I am Yobele David, and I head the Strengthening Health System at Budget Foundation. So we are currently working with partners to improve community voices. So we're doing a community-led engagement session, and we've been in the state. And the first point of our engagement was when we noted that out of the 15 facilities that we had visited, 11 of them were requesting additional human resource for health. And the human resource for health that they were requesting was not only the doctors, but also the support system that needed these facilities to run. Now, the community-led initiative or engagement went further to take retired citizens, to take community volunteers, to say, how do we incorporate people so that our technical people can have some form of focus on the technical issues and then addressing some of that. So the community-led initiative is a direction in which community members are taking ownership and are being the catalyst for which we see the change that we want to strengthen the healthcare system. This does not only involve human resource for health, it also involves the policies. It's also building the strengths of the capacities of the WDCs. Yesterday, we were in a meeting with some WDCs, and the WDCs are no longer keeping quiet. They're writing. They're putting it in paper, black and white, and they're saying we want to be seated on the table when these discussions are going on. We want to have inclusion. We want to have the needs assessment done, and we want to come back to the board and sit down with the facility representatives to say we need to have an improved service delivery in our community. So this is part of the work we're doing here. We currently have a platform called the phctracker.org. And in this platform, we have over 200 facilities that are being profiled. You can visit the platform. It's called www.phctracker.org. You can visit the platform. You can check what your community is saying from the services that are going on. They're saying about the performance of their health workers. And part of this thing we had done in the last meeting we were, where Dr. here represented the Commissioner of Health. You remember? Where we had an appreciation service for health workers. Somebody said something which is very crucial. Health remuneration is key to having people stay. Because I ask a simple question when I walk into a facility and I say, if you have the opportunity and you are invited to a different country to serve in the same capacity, would you stay or would you go? That's a dilemma. A person has to make that decision. But how do we improve? How do we look at the remuneration? How do we also look at the acknowledgement for the health workers that are currently on board? So in summary, we're working together with Engender Health. We're working with the Nigerian Health Watch. We are going to be sitting down more now on the table to say, how do we harmonize our findings? We are doing the community engagement aspect of it. We are doing the community mobilization. We are doing the advocacy visit. We are doing also the sensitization. We are building the capacities. We are conducting baseline examinations. We have data. As much as possible, we are at the forefront where we are saying we are not fighting government. We want to strengthen. I can give you data of close to about 10,000 feedbacks in Kaduna State. And I have read through every one of them. People are telling us we need running water. We need additional human resource. We are not comfortable with the medications in our facility. We are having this, and community members themselves are mobilizing to champion this cause. So thank you very much for listening. And we will hope to be actively involved in the work that is ongoing in this room. Have a good day.
Please a round of applause again. I think it's been very insightful discussions that have transpired here today on both the first and second panels. Insights which I believe will be instrumental in improving health outcomes in Kaduna State. At this point in time, I would like to call on Yasser Bakari, who is our monitoring and evaluation officer at Nigeria Health Watch, to talk about our post-event survey. Please a round of applause for him as he takes the stage. Thank you very much.
Standing on the existing protocol. Good afternoon once again, everyone. I must say it has been a very interesting, educating, and informative session that we even having this morning. And it is said that everything that has a beginning must come to an end. But before this policy dialogue comes to an end, we just want to gather your thoughts. We want to hear from you. And it is also said that every feedback is a gift. We need your feedback on this informative session that we've had so far. And so the live vendors are going to, so yeah, this is it. We would like you to scan the QR code on the screen right here. So this QR code will lead you to a link tree where you see a list of links where you just tap on the post-event survey for policy dialogue. So the first on the list is our feedback survey, and the second on the list is to subscribe to our newsletter. If you want to hear more from us, if you want to read more of our articles, either Touchlight or Thought Leadership articles from Nigeria Health Watch, so please scan the QR code and take this survey. We would really appreciate it. So for this survey, we just want to gather your thoughts on the overall performance of this event. How relevant and valuable has the sessions been so far, right? From the presentations to the first and second panel sessions. Have you been able to, make new networks or strengthen partnerships that you can hear? And then how do you hope to cascade the learning from here to, the larger community, among your peers, among your networks, and even at your workplaces? So just a few minutes, we would like to hear from you. Thank you very much once again.
This is a round of applause again for Yasser. As he has mentioned, we at Nigeria Health Watch are very intentional about these sorts of events that we curate. We don't just do this for hosting your lovely selves, but ensuring that the objectives of curating these sort of gatherings are met. And as he had rightly mentioned, every feedback is a gift, and which we use to inform the development of our subsequent events. So please, we would appreciate your feedback via the post-event survey that Yasser has mentioned. Right now, I will be calling on Mr. Sheriff Badamosi, who is our Advocacy and Community Engagement Manager. He has meticulously captured the various insights and commitments that have been made during this meeting, and will be reiterating those to us via our communique. So please, a round of applause. Okay, just before then, I would be calling on, correct, yes, I am very sorry. I think before Sheriff comes up, I'd like to acknowledge Zachary Mohammed, who is the permanent secretary for the General Service. He is they're representing the secretary to the state governor, Kaduna State or government. Please, a round of applause for him. It's lovely to have you with us today, sir. So at this point in time, please a round of applause to Sheriff Badamosi as he comes up.
Distinguished guests, panelists, and stakeholders, standing on the same protocol. So permit me to present a brief communique of our engagement today with you
and every stakeholders here present. So I'll be presenting on the first panel section and second panel section and our key action that I've listened to from this event. So on our discussion revealed that while budget allocation exists, cash releases remains inconsistent, which are currently being worked on by the state executives and government, which has also been leading to stalling of real impact. So we also learned that many government staff involved in budgeting still lack technical capacity for content-driven, priority-based planning. On the positive side, Kaduna State government initiated quarterly mutual accountability platform, which is a great start. But there is still a strong call to strengthening these mechanisms, especially deepening citizen partnership in tracking how health funds are actually spent. So we also had promises, insight from community-led tracking efforts, such as the volunteering, monitoring antenatal services, showing how gas government can drive accountability and ensure value for money. The panel emphasizes the need to improve budget tracking, feedback loops, and internal coordination, especially between Ministry of Finance and Health. The importance of routine performance review and use of real-time data was also raised as critical tracking financing gap. In terms of action, the panel recommended: 1, building government staff capacity for realistic, healthy priority budgeting. 2, institutionalizing quarterly review meeting with CSOs, communities, and other stakeholders. 3, expanding public awareness of health insurance and other financial tools. 4, scaling innovative models that reflect local realities, including blended financial private sector partnership. So in closing of the panel 1 section, the panel stressed that financing PAC equitability isn't just about money. It is about transparency, trust, and consistent collaboration. So in panel 2, we also have discussion about closing the health workforce human resource. At the moment, to close this gap, the government plans to recruit 1,800 new health workforce every year in the next 5 years, bridging the coverage to about 42% from 32%. However, recruitment alone isn't enough. Rural deployment remains a serious concern. Staff are unwilling to work in hard-to-reach areas due to poor incentive and inadequate housing. The state is responding by deploying a new human resource for policy, health policy, with rural allowance, accommodation, and structured recognition. Community health volunteers are also being instrumental, but their role must be formalized with contract, compensation, and a clear accountability system. The panel draw lessons from countries like India and Rwanda, where community-based health workers and government-supported are using outreach models to succeed where hard-to-reach settlements need to be reached with healthcare infrastructures. So in the closing note of the panel section 2, the core message is that we need execution. Kaduna has a policy plan in place. The focus now must shift from financing into action and implementation. And the panelists also emphasized that solution to Kaduna workforce challenges does not lie in more strategic documents, but in bold execution with political will, sustained financing, coordinated partner support, and ensuring that every community have access to skilled, motivated health workers that ensures that the government of
Okay, good afternoon. Good afternoon, everyone. Thank you so much for an amazing time. I think the calls to action are very clear, so I would not repeat any of those. The communique has been read out, but I would just like to use the time to say a big thank you to all of the stakeholders, to the Kaduna State Government, to the permanent secretaries, the Director Generals, all the directors in-house, the Commissioner for Health as well, who made an appearance early, to our partners in gender health, to budget, to the BHA Nigeria, CHAI, media representatives, all of our other CSO colleagues, the open budget partnerships as well, to the representatives from the parliaments, from the SSG. Thank you so much. And thank you to the Nigeria Health Watch team. This is our first time convening a policy dialogue in Kaduna. So as you can imagine, it was a learning curve, but we had so much support. A very special thank you to Dr. Anthony Shamang, who was our legs, our legs in the city. So thank you so much.